A very good day to one and all. I am Dr. Rohit Gopinath. Today I'll be giving you a basic introduction on neoplasms. Now, Willis defined neoplasm as an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissue and persists in the same excessive manner even after the cessation of a stimuli. So this is an important, each component of this definition is important, because basically neoplasm is an abnormal mass of tissue, and more often than not the growth of this mass of tissue exceeds its own blood supply and its own capabilities, and it is uncoordinated when compared to the surrounding normal tissue, and the inciting factor which produces this exaggerated growth, even if it is stopped or it is removed, this growth continues. So all components of a neoplasm have been concised and brought together in this definition. So to reinforce, Willis defined a neoplasm as an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue and persists in the same excessive manner even after the cessation of the stimuli. So there are 6 P's associated with a neoplasm. So it is progressive, the growth is purposeless, perverted because it is out of the ordinary, it is persistent, it is pervasive, and there is a proliferative mass of tissue. Now, any neoplasm can be broadly classified as benign and malignant. So benign neoplasms are well differentiated, whereas malignant neoplasms lack differentiation. Now, structures are typical of tissue and the cell of origin, whereas atypical structures with anaplasia are seen in malignancies. We'll be discussing about these terminologies like anaplasia in the later slides. The growth pattern in a benign tumor will be slow, progressive, whereas in the case of malignancy, it will be a rapid growth. Normal mitotic figures are seen in benign lesions, whereas abnormal mitotic activity is seen in malignancies. Benign lesions are usually well encapsulated and localized, whereas it may not be so in malignancy. Benign lesions do not infiltrate normal tissues, whereas infiltration is a common characteristic of a malignancy. Metastasis again is not seen in benign lesions, whereas malignancies, the tendency to metastasize is very high. Benign lesions are better cured with a surgical excision, whereas malignancy might require other adjunctive modalities in the treatment. And of course, remember, benign lesions when removed completely will not have recurrence, whereas malignancy has a very high tendency to recur. Among malignancies, the 2 most important types of malignancies are sarcomas and carcinomas. So sarcomas arise from malignancies which arise from mesenchymal tissue, whereas carcinoma arise from epithelial cells which can be derived from any of the 3 germ layers. Sarcoma itself means fleshy tumor, whereas carcinoma in that C-A-R-C or cars means crab-like. Sarcomas usually have a smooth, firm and hard swelling. These are usually smooth, firm or hard swellings, whereas carcinomas are usually hard, can be ulcerative, ulceroproliferative and have everted edges. For example, like a squamous cell carcinoma. The edges can be other than everted. You can also have rolled out edges like in basal cell carcinoma, etc. Sarcomas usually are warm and highly vascular with dilated veins over the surface, and it has a very high tendency to produce hematogenous metastasis. That is, it spreads via the bloodstream to the lungs or to the liver. Common sarcomas are liposarcomas and fibrosarcomas. Carcinomas predominantly metastasize through lymphatics. Of course, hematogenous spread of carcinomas is also documented. We'll be discussing about that in the later slides. So any tumor, any neoplasm has 2 components to it. It has a parenchyma, it has a stroma. So parenchyma is the one which contains all the malignant cells, whereas the stroma is formed by the connective tissue and the blood vessels that supply these proliferating malignant cells. Neoplasms, particularly malignant neoplasms, they exhibit what is called as Gompertzian growth. That is, the growth of any neoplasm is exceedingly fast until it is first clinically detected. After it becomes clinically detected, the growth of the organism, growth of the cells progressively decreases compared to its initial growth. So this is what is called as Gompertzian growth. To summarize again, Gompertzian growth is nothing but you find that malignancies tend to proliferate at a very high rate before they are clinically palpable or clinically detected. Once they are clinically detected, the rate or the growth rate tends to come down when compared to previously. So this is what is called as Gompertzian growth. It takes at least 30 divisions to get a clinically palpable or clinically detectable malignancy. For a 1 millimeter lesion, you have 10 raised to 9 cells within it. So that's how long it will take for us to clinically detect it. And this one reason for this restriction or decrease in growth as it becomes clinically detectable is because it outgrows its own vascularity. Now, with relation to malignancies, there are 3 important terminologies that we should be familiar with. One is anaplasia. So, anaplasia is characterized by a lack of differentiation. So, by looking at an anaplastic cell, we may not be able to characterize it into any particular cell type. So, there is lack of cell differentiation. There is pleomorphism. There is hyperchromatism. Anisocytosis, because the cell sizes will vary. Anisonucleosis, nuclear size varies. And there is abnormal mitotic activity. So, these are the characteristics of anaplasia. Now, the other 2 important terminologies associated with malignancies are dysplasia and carcinoma in situ. So, dysplasia, the terminology basically means disordered growth. There is lack of uniformity of cells, and there is loss of architectural orientation. These also exhibit pleomorphism and hyperchromatism like you would associate with anaplasia. Now, dysplasia, it progresses towards carcinoma in situ. When you have a dysplasia involving the entire thickness of epithelium but does not involve the basement membrane, then we call it a carcinoma in situ. So basically, it is a pre-invasive lesion. So carcinoma invasive is basically a dysplasia involving the entire thickness of epithelium. The basement membrane is not involved and it is pre-invasive. So this is a picture which is showing us a typical carcinoma in situ. You can see that this lesion is involving the entire epithelial lining, but the basement membrane is not penetrated or involved.